Gary, thanks. That was wonderful. Let's move to Dr. Tara Dall. Tara, you're a lipidologist, and we like to quote you. One of the things you say often is that lipidology gives us the magic window into the earliest understanding of human disease. We love that quote from you. And so what Gary's talking about is insulin resistance and problems like that. How does that apply? How can a lipidologist help us in this regard? That's one of the things we want to know. And the other thing we want to know is there a role for metformin early on in the patient who might be at risk for developing Alzheimer's disease or dementia? And the third thing, that I don't mean to give you too much, but the third thing is it just keeps coming up, ApoE. ApoE. Tell us about ApoE, because some of the ApoE patients have much more risk of developing these horrendous problems. So if you could clarify that for our police and firefighters, we'd really like
Sure.
that.
So as a lipidologist, one of the things that I'm trying to accomplish when I see a patient is how can I best prevent cardiovascular disease and certainly diabetes. And we fail to prevent those diseases usually until there's an event that occurs, and then we start to backpedal and try to aggressively address risk factors. But it's so much more effective if we can target disease even before it's even there. When we recognize genetically that a person is really at risk for something, there's so much more we can do early on, even just with simple things like diet and exercise before a disease has manifested itself. Because even once diabetes is there, you know, you've lost 60 to 70% of your pancreatic function by the time you're diagnosing it. And at that point, yes, there's medications available, but it makes a whole lot more sense to try to tackle that process much earlier. So if we're accepting of the fact that insulin resistance not only contributes to diabetes risk, and certainly cardiovascular disease, but now we're recognizing, as Gary said, that clearly there's a role that insulin resistance plays in many other disease states, and including Alzheimer's disease. So the question is, if we're going to do something to prevent these diseases from happening, what we really need to do is be able to identify that that's the path we're headed on. And insulin resistance seems to be one of those core pathways. So how do we figure that out? Well, one of the reasons why we don't have drugs approved for insulin resistance and diabetes is it's just not a well-defined problem. I mean, we don't really have a clear diagnosis that's acceptable, that people agree upon. We have this metabolic syndrome, which we've defined as if you have 3 out of 5 criteria, you meet, you have metabolic syndrome. So if you have elevated blood pressure, if you have elevated triglycerides, if you have a low HDL cholesterol, which is the good cholesterol, if you have elevated waist circumference or abnormal glucose, that defines you as having metabolic syndrome, which is another way of thinking about somebody that has kind of an insulin resistant state. Unfortunately, it may be years before somebody really has enough criteria to qualify. And as a lipidologist, I see people all the time that have 1 or 2 of those criteria. They don't have all of them, but I'm really highly suspicious that insulin resistance is part of the root cause of that risk for cardiovascular disease, or that potential diabetic state. And if I want to do a good job addressing those risk factors, I need to know how to treat it. So my way of treating lipids would maybe be to put people on cholesterol medication. But maybe if your cholesterol and your lipoproteins are abnormal because of insulin resistance, then maybe the way to go about that is actually to targeting that root cause with other things like low-carb diet, exercise, or metformin therapy. So one of the things that I've utilized for the last 12 years in my lipid-related practice is an NMR lipo profile, which I know we've done educational sessions on before. What gets me so excited about this is not just the opportunity to identify cardiovascular risk, recognizing that if people have elevated LDL particle concentrations, they're at risk for cardiovascular disease, but also there's all these other shifts in lipoproteins that happen in the very early stages of insulin resistance. Meaning, you begin to create small, dense LDL. You begin to get a lack of the large HDL particles, which are more protective. You get the surplus of large VLDLs, which are really dysfunctional particles. And that story that's being told from the lipoproteins is telling us something. It's telling us this patient is heading in a direction where they could develop diseases like cardiovascular disease, diabetes, and even Alzheimer's. So if we really want to do a good job preventing that, we need to be able to identify it up front. So again, in an NMR, you can identify insulin resistance story. They have an insulin resistance score. If that's over 45, it means this is happening. And you know, what's interesting, having seen hundreds, I mean thousands of patients now, there's people with totally normal traditional lipids that have absolutely abnormal advanced particles. So they have small dense LDL, and they have, you know, significant disease that we never would have been able to pick up on. So that's cool. And what's even more cool about it is not only can we pick up on it, but the treatment. If it's diet, obviously that's cheap. But if we have to go beyond diet, we're talking about using a drug like metformin, which is widely accepted for treating the insulin-resistant state or the pre-diabetic state, and it's dirt cheap. It's generic. It's available in many pharmacies almost free. So we're not talking about identifying something that's going to cost society this massive amount of money. I mean, maybe we're better off just putting, you know, the majority of people on it just because of the prevalence of insulin resistance and all the diseases that tend to follow it. You know, it's interesting. So that window is, to me, that's just incredible. I mean, there's many cases of patients that have not had heart attacks, don't have any indication for lipid drugs, but have very abnormal particles, and we're able to fix that by just addressing the root cause, by addressing the insulin resistance with a low-carb diet, exercise, and things like metformin. And we even go so far as to sometimes utilize some of the other diabetes agents that really are effective at treating insulin resistance much earlier in the disease state. So that works. The other question you asked about with ApoE, that's something that's another test that some lipidologists order routinely, some order more selectively. An ApoE genotype gives us some information about risk. We know that a normal ApoE genotype is a 3-3 pattern. That's what the majority of people will have. If you happen to have a mutation where you have, instead of a 3, you have a 4, and this is a DNA mutation, a different allele, we know that that's associated with increased cardiovascular risk. If you have a 3-4, you have a 5-fold increased risk. If you have 2 4s, you actually can have a 20-fold increased risk for cardiovascular disease. But we also know that that 4 mutation is also associated with Alzheimer's disease. And so there's a number of things we can determine by understanding someone's ApoE genotype. If somebody has a family history of Alzheimer's disease, dementia, and they have a 4 genotype, you know, certainly we want to do everything we can preventatively up front. So, you know, there's lots of different things we'll maybe talk about that we can do to try to prevent or eliminate or decrease progression to dementia. And one of those pieces is obviously addressing insulin resistance, but there's certainly many other therapies, I mean, related to different types of oils and other things that we can use. So it's interesting to be able to identify that risk and then be able to more effectively go about being as, you know, preventive as possible.
One of our dear friends who's been a supporter of this program had, back when we were in the Berkeley days, had the ApoE determinations in his 4. And this lady is obsessed by it. It's not all, sometimes it's a two-edged sword, the ApoE. What do you think
you know,
about that?
I've struggled with this a long time myself. You know, I'm an information gatherer. I love doing lab tests, and I personally didn't get my own ApoE genotype until just about a year ago for the reason being that my grandmother died of early Alzheimer's disease in her 60s. And every time I can't remember where something is, I wonder, is it this? Is it happening? Is it me? And so I was one of those where I really didn't want to know that information. And I think that brings up a very important point. I mean, we talked about 2 different types of testing. You know, obviously identifying lipoproteins putting at risk for insulin resistance has a lot of cures. I mean, you can actually fix that problem. It's not as though you just cross your fingers and hope you don't get it. There's so many things we can do. With the Alzheimer's risk, it's a little bit less clear. We don't have a cure for that. We don't have sort of a drug we can put on board that's going to definitively help that. And so I think it's important anytime we utilize genetic testing that we're making sure patients are okay with the implications of that. And you know, some people really psychologically can't handle having that sort of in their back pocket, recognizing that that's a potential risk of theirs. So I think it's something that really has to be carefully, you know, chosen and set up front, really counseled on, because you don't want to make the mistake of giving someone information they don't want. I mean, there's people in this world who don't want to know if they carry the breast cancer gene. You know, they don't want to live with that knowledge. There's others who want to know and will do a radical mastectomy just to be able to prevent the risk. So I think it's going to be patient-based when it comes to that.
The question is always going to be, can you act on what you learn?
Yeah.
And so the answer is, you know, with the ApoE alleles, you really can't act on it, but you can act on it without learning it. in effect, by doing what you need to prevent insulin resistance to begin with. So whether or not you're at increased risk, it is good evidence that you can lower your risk across the board by lowering your, getting rid of your insulin resistance. That can be handled first by diet and then by drugs, if diet isn't good enough.
Absolutely. I also want to point out, too, just so that nobody misunderstands, if you do have a mutation, a 4 mutation, there is increased risk, but it doesn't mean it's definitive. It doesn't mean everybody with Alzheimer's disease has an E4 genotype. In fact, I think it's a little more than 50% of people with Alzheimer's do carry that genotype, but not everybody has it. And there's certainly other people that have, it can go both ways, where they carry the genotype, they never develop Alzheimer's disease or any evidence of dementia. So you don't want to presume that by having that, it definitively means something. I mean, it tells us about a trend and a risk, but it doesn't define the patient in a way that's definitive. And I think it's important to recognize that too. Not put too much fear in our hearts and do a lot of the things we can do, just normal preventive things. That by preventing insulin resistance, we're not just preventing Alzheimer's risk, we're preventing, cardiovascular disease, diabetes, and who knows how many other disease states that are going to be impacted by the insulin resistant, state. So.